And I'll go ahead and introduce you to our next speaker, Dr. David Wheeler. Dr. Wheeler is a physician consultant for the Infectious Diseases Physicians Incorporated. He's been a managing partner there since 2012. He's also the chief of infectious disease section and professor of medical education at the University of Virginia at the Inova campus. He got his BA and MD from the University of Virginia. I am a Hokie, but we won't say anything. I still love you. Intern and residency at University of Colorado Medical Center, has multiple faculty positions with Virginia Commonwealth University, Georgetown University, and University of Maryland School of Medicine. And the way that VDH knows and loves him, since 2006, he has been on our AIDS Drug Assistance Program Advisory Committee and has done great works with us. So thank you. Please welcome Dr. Wheeler.
Thank you all. So to control it from the little buttons on the laptop or the?
That right or left, there you go.
Okay. Yeah, thank you and good morning. So I'll be providing sort of perspectives from the clinician side of things on managing patients. I had the circumstance to participate in the care of a number of patients during 2022 during that summer. I think I took care of about 10 to 12 men who had Mpox and kind of went through the journey with them, and with one sad outcome of one of our patients, and I'll share a little bit about him as well. And so with the Virginia response, I'll sort of touch on the testing, the monitoring symptoms, and the facilitating treatment. So as was mentioned in the first talk, we have the two clades, and our first experience with Mpox sort of in the public health and clinical care community was with the clade 1 from the Congo. That was primarily seen in children with animal contact. There wasn't really person-to-person transmission, and sort of a rash where all of the lesions were of a similar age, if you will, kind of like we were experienced with smallpox back in the old days. So this was sort of the pictures that came out of the initial cases of these very tense bullae on the body, and this disease actually had a mortality rate of like 4%. So it was a pretty bad infection for kids in Africa. The current outbreak that came through Western Europe and the United States, and now, as was very nicely outlined, sort of was spread across the world in low levels, is the clade 2B. And it's a little bit different as we've gotten our experience. It has an incubation period as little as 2 or 3 days, so the period after which you've been exposed before which you have any symptoms, but can be out to like 14 days. Often, but not always, folks will feel sick for a few days. So headache, fever, body aches, swollen lymph nodes, and then the rash comes out. And these rashes have been almost like chickenpox in the sense that one can have different ages of the lesions. And I'll share some pictures with you of those. And then they usually will resolve on their own. And the mortality rate is quite low, and actually the number of deaths was already outlined for you, across the country. It wasn't that many cases, and I think in Virginia we had 2, one of whom I helped take care of back in the summer of 2022. So the examples of the lesions go all the way from small papules and pustules, vesicles, all the way up to scabs. And this is kind of the progression going across the top 3 and then moving across the bottom 3 to where you actually have healthy skin growing over it. And here's a couple of examples of some of the patients that I took care of. Here was a young man who presented with just a couple of discrete lesions. Now, if this epidemic sort of reappears and we're called upon to evaluate people, these lesions are pretty characteristic. When folks present with these type of discrete lesions, often they're sort of fat and sort of pussy looking and have a central umbilication, And most of the people that I saw had at least one of the lesions that looked something like this. And in this epidemic, they had a preponderance of lesions in the genital area as well. Now here's examples of like a cluster of these little lesions on the chest, and then on this young man's chin, this sort of scabby, almost like impetigo look as the lesions would sort of rupture and then stay kind of crusty looking with almost like a honey-colored discharge. And since we're a clinical audience, I can share these types of pictures where frequently men will have penile lesions with a lot of edema. So edema was a big part of it and very uncomfortable and concerning for the possibility of stricture formation and scarring later, which is one of the reasons why treatment is offered to those individuals, even though, as we'll get to, probably most people don't need any particular antiviral therapy. And here's an example of an anal lesion. And this is another example of the edema and a lot of pain with this too. So folks would be very uncomfortable. And with the perianal lesions, they would have rectal pain, pain with moving their bowels, and a fair amount of distress. Now, as has already been mentioned, immunocompromised folks are more at risk for having severe disease. And in the outbreak in the United States, about half of the patients with Mpox had HIV as well. And so it's really important, I think, as Jorge mentioned, that if you're thinking of testing for HIV, or if you have folks who present with Mpox, absolutely, if you don't have their diagnosis, you test for HIV infection. A key thing that I did find in the summer of 2022 is misdiagnosis, though, of other vesicular and pustular conditions that are not Mpox. And two cases in particular, one was varicella in an adult who had been exposed to somebody with dermatomal zoster. And that poor man probably went a week without antiviral therapy while there was this tremendous fear about letting him come in anywhere because he might have Mpox. So I think there's a bit of an excessive infection control around Mpox. As far as we've seen, it doesn't like jump out at you across the room. It's skin to skin contact. It's contact with clothing or towels that has been in close contact with another person. So in 2022, it was a new thing to us, but there was this inordinate fear. So people who had other conditions that needed treatment went without treatment because of this fear of letting people come into your place of clinical care. So I think contact precautions is the key part of it. Now, as an infectious disease doctor, I'm asked to give good examples, so I'll put on my mask and my goggles as well. But I don't think I'm going to breathe in Mpox from somebody that I'm examining in the exam room. Now, if they're getting intubated or they're waving towels around like they shouldn't be, that might be a different case. But the other was an older person with zoster who didn't get antiviral therapy for many days while they're waiting for the Mpox result from this quick swab that was done in the ER. And there are other certainly pustular conditions, MRSA folliculitis, staph folliculitis, herpes simplex, syphilis. But usually what I found was chickenpox and zoster were the two that got confused that summer, and some folks went without care. So be mindful of contact precautions, do the testing as we'll touch base, but keep an open mind to what other things that could be. So I did have a gentleman who came in August of 2022, was referred after he'd already been in care at a couple of other places. 38-year-old man, little past medical history, had had a rash for 3 weeks, had actually been to the ER twice, and was told that he had an allergic dermatitis and got 2 rounds of prednisone. And he felt better after each round of prednisone, not surprisingly, and then felt a lot worse after he finished the prednisone, and had a tremendous amount of anal pain. these were some of the lesions on his body. These were larger than what we would normally see, almost like ulcerated lesions like this. And he had crops of these lesions all around his bottom and on his scrotum as well. And it turns out he had HIV infection, and we ended up taking care of him. I'll share a little bit about that later. For the testing, it's a little confusing in the information that goes out there because there's actually different labs prefer to have the swabs done differently. In our office, we use LabCorp, and so LabCorp and Quest do the testing. It's the easiest way to do it because you can send it out, and it's the pink viral culture media. So LabCorp and Quest want it that way. I think VDH, I think, prefers the dry swabs, but since we don't use them, I highlighted here the information, the test code, the CPT code, 3 to 4 day turnaround, and you take one of their swabs. It's not a cotton swab. It's one of the artificial Dacron or polyester swabs. You want to do pretty vigorous swabbing across the lesion, and then if any of them leak and you get a little bit of that liquid, that's even better. The recommendation is that you don't try to pop them, and I think that's to avoid accidentally sticking yourself with the needle and what would be quite infectious. That's the way you would transmit Mpox. But good vigorous swab on a couple of lesions, maybe even a couple of the swabs, and then pop them into the viral culture media, put it in the refrigerator, send it to LabCorp, and they can turn it around. It's a PCR test, so it's pretty sensitive if the virus is there. Now, in terms of treatment, the truth is that the majority of people with clade 2B who are immunocompetent and get Mpox, it's going to be a mild course of illness, and either A, they don't need antiviral therapy, or B, we're not really sure how well it works, which is why we're going to get to the STOMP trial, which is an important thing. Like with COVID, where we get something, we want to use it, even though does everybody with COVID need Paxlovid? Probably not, but if we want to have something that we want to use, antiviral therapy is something that I had the chance to use some in 2022, but probably most people don't need it. But what they do need is they need supportive care. So pain relief, reassurance that somebody's going to keep a close eye on them until they get over this, and then the rationale for and the indications for antiviral therapy. So of the antivirals that are out there, and this was sort of the first slide that came out back in 2022 as we were trying to figure out what do we offer people. So the TPOXX, so tecovirimat, it was an antiviral that had been developed for smallpox, but it was based on animal studies and some initial sort of empiric work with it, no clinical trials that really helped us determine. But one of the things was it's very well tolerated and seemed to have a rationale. The other antivirals, the cidofovir, is available as an IV medicine, but it's pretty toxic. And again, we don't have lots of good data. And then at the bottom, the brincidofovir is an oral version of cidofovir, but in the studies where it was used, it was pretty toxic. So we pretty much stay away from those. The vaccinia immune globulin is an immune globulin that is available in limited amounts. It's available through the state health department, and it's used for people who have a very bad reaction to smallpox vaccination, so that the vaccinia virus in an immunocompromised person could cause disease, and the vaccinia immune globulin was used in that setting. But it was available and potentially some role with severe Mpox. So the TPOXX comes as 200 milligram capsules. The pharmacy at VDH is very easy to work with and supportive, and could overnight the medication right to our office. It's 3 capsules twice a day for 14 days. Again, we don't have a lot of good study data on it, which is the reason why they set up the study just as the epidemic sort of waned. So they hadn't been able to really study it yet. It works intracellularly where the virus has been invaded the cell, it's ready to come out, and it gets coated with membrane from the endoplasmic reticulum, and this tecovirimat blocks that step to block the viral replication. So for adults who are above 40 kilos and below 120 kilos, it's the 3 capsules twice a day for 14 days. Now, in the patients that I took care of, and I think I treated about 10 of them with the tecovirimat, they got better. So this was a patient with day 1 with some lesions on his skin and the edema in the penis. And on day 4, already the lesions were drying up. The edema was getting better. Day 11, he was already getting kind of healthy skin growing over. And the swelling had gone down considerably. Well, the only problem is, how would he have done if we hadn't treated him at all? It might have been that he would have had a similar course. So the Mpox is available if we order it through CDC, although here in Virginia, we can order it straight from VDH, and I'll put a plug-in for their website. It's very good. You go to the VDH website, it tells you exactly what you need to do if you want to order it, and it directs you to the preference of the STOMP trial. Now, the indications for treating a person with Mpox would be if they have severe disease. I didn't see anybody except for the one person that I'll finish sharing with you with the advanced HIV who had severe disease, but the anatomic area, so the penile pain or rectal pain was often an indication to treat with the antiviral. And certainly folks with recognized HIV infection, that made sense to do so as well. But the preference is to refer to the STOMP trial. So this is a trial. There's a number of sites. Unfortunately, there's not any locally here in Northern Virginia, but VCU has a site. Duke has a site that reportedly, I think, can do the study visits virtually. And Hopkins has a site as well. And the importance of it is to try to find out, is this helping? So if the person's willing to go on the study, they don't have to qualify as severe disease because they just really want to get folks where we're trying the medicine. And I'm quite comfortable with it because the medicine, as I said, is very well tolerated. We didn't have folks with any side effects with the medication. If a person needs the treatment and doesn't want to be on a study, it's available. And as I said, the VDH pharmacy can overnight the medications. It is an experimental drug for use for Mpox. So a physician would have to be willing to jump through a few hoops to do the FDA requirements. But I found them to be pretty easy to do. And most of them, you just do it once, and then they'll send you up to like 10, enough for 10 doses for treating 10 people. And then you can have it there. So if the epidemic recurs again, we can have some places that have a supply. And so I think the reason I ended up seeing so many patients is once I had the supply, then I would get these little friendly calls from Alexandria and Fairfax County health departments about, hey, would you mind seeing this person today or tomorrow? And we would usually do that. Oh, and then here's just a little shout out, and since there'll be the slides will be available, you just put in your web search Mpox VDH, and boom, you're right at their site, and it's pretty easy to find the places that you need. So with the young man that I took care of, he had not had prior diagnosis of HIV. He was seropositive, had a CD4 count of 17. He had thrush. And initially, when the first day I saw him, I thought it was because all the prednisone he'd been getting. So it probably was both, the prednisone. And, to what degree the prednisone made the Mpox worse, I'm not sure, but it probably didn't help. So initially, I treated him as an outpatient, but he only lasted a few days. He just was so miserable, and he started getting short of breath, and we admitted him to the hospital, ended up having pneumocystis, so we treated that. He was on the oral Mpox. And then VDH was able to get us the intravenous Mpox, which we put him on. And so even after 2 weeks, he still had these large crusty lesions, but he seemed like he was getting almost a little bit better, um, with drying up of some of the lesions on him. Um, and then he just started getting worse. And according to the CDC experts, so we were on the phone with them a few times, that it seemed like it was a pattern with some of the other folks with advanced immunosuppression, where it just at some point, we don't know whether they got resistant to the TPOXX, or if it was more of like immune reconstitution as we're giving the antiretroviral therapy, because we wanted to get his immune system stronger. And then it just sort of exploded. So this is after a month on treatment. He had all these lesions all over his face and his mouth. Um, and his bottom was just like confluent pox lesions all over his bottom. And then he ended up then going into organ failure and dying. Um, and it was sad, but we sort of felt like we did everything we could. And the CDC at least told us that of the other, so I guess there were 16 other people that died, that it was a similar kind of thing with advanced HIV. So again, another plug for identifying our folks who have HIV infection and getting them into treatment before they have Mpox, or any folks with Mpox to go ahead and look for it. And we had an excellent presentation about the Jynneos vaccines, and our folks with HIV can absolutely get vaccinated with it, and getting folks who are at risk vaccinated is key. It'll be important for us to identify whether TPOXX is really helpful and working, and then we can be more judicious in how we use it, or offer it to more people if we feel that if it's worked, because again, it is very safe to use. And the other antivirals are not, probably aren't particularly useful. We did actually give him a dose or 2 doses of the vaccinia immune globulin too. That, it didn't help him, and we're not sure to what degree, if it's because it doesn't work or he was already past being able to be helped. And then I'll put in a plug for the screening for other STIs, but also keeping your mind open for other infections that could look like Mpox, and that you don't want to be withholding treatment for those things while you're waiting. The test turnaround time is fairly quick, but for some things like chickenpox in an adult, or severe zoster in a vulnerable area, you want to get them on treatment for that as well. Okay, thank you.